Thank you all for coming this evening. I'm really delighted to be hosting Michael Healy this evening for the quarterly Chiari Stringomylia Foundation lecture series. And I think we've been doing this lecture series now for about 6 years, is that right? And I don't think we've missed any of the events. But all of our speakers have been superb, and tonight I think Michael Healy fits right into that category. He practices at the Healy Institute in Providence, Rhode Island, and with his wife, and has another practice in Cumberland, Rhode Island. He teaches Little League and youth soccer. He graduated with a Bachelor's of Science from New England University in '86, and then did an MBA in 1997. He took a doctorate in osteopathic medicine in 2008, and then a doctorate of physical therapy at Simmons University in 2012, and since then has been operating the Healy Therapy and Sports Medicine Center in Providence. I know Michael because I think he's now world famous. He is a really brilliant person, and he's one of the few people that I invite to help diagnose my patients' problems, because he has such a sensitivity to the spine and the muscles and what's going on. So he's a brilliant diagnostician and a brilliant treating physician. And he works harder than anyone I know, except me, and Dr. Lee. And so I'd like to introduce Michael.
Before I start my presentation tonight, I just want to go over some basic anatomy with you. I drew it up here because I couldn't do it on my PowerPoint. I wasn't that sophisticated with my PowerPoint. But I just want to show how the total body gets affected when you're treating or looking at a patient with either a Chiari malformation, craniocervical instability, or any patients that have any type of connective tissue disorder. A lot of my colleagues in physical therapy, when we get a diagnosis of neck pain or just craniocervical instability or a Chiari, we only look at the neck. And that's a big mistake, because there are a lot of other symptoms that go throughout the entire body, and if we don't look at the entire body, we're not going to see the whole picture of the patient. So before I start my presentation, I just want to show you how and why you may have symptoms in other parts of your body before we go with the presentation, okay? So I drew this little thing. This is your foramen magnum, the hole in the back of your skull, your tentorium membrane, which is inside your skull. Now, attached to it is your dura mater. It's the outermost covering of your spinal cord, and dura mater means tough mother. It's a really tight band, and it's on the top of the spine to protect it. It's very sensitive to pain. It attaches into the foramen magnum, into your C2 and your C3. It comes down and attaches down to the down into the S2, down in the spine. So if you have any problems in your neck and you're pulling the dura, you can actually get some problems going down to your S2 in your low back. So you can get some low back pain with neck pain, and vice versa, back pain with neck pain, just through that connection. Now there are a couple of other connections coming out through here. Your tentorium membrane, your diaphragm, and your pelvic floor, all three of them, from an osteopathic standpoint, work together. So if there's any issue in either one of them, you could be pulling on another part of the body as well. Now, coming out of C3 and C4 and C5 is your phrenic nerve, which comes out through your neck, attaches into your diaphragm. Your diaphragm attaches to your thoracic spine to the front of it, and then you have these cura that come off and attach to L2 and L3 to your lumbar spine. So if you have a problem at your diaphragm or in your neck, you can end up with a problem in your thoracic spine or cervical spine, or cervical, thoracic, and lumbar spine. So there are a lot of connections that we have to understand as therapists and physicians when we're looking at our patients. Also, when your occiput tilts back, you get a pulling up on your dura. Also, as you go into extension with your neck and your occiput tilts back, your sacrum will also tilt back. You bring your occiput into flexion, or it comes forward, your sacrum will flex forward. we call that nutation, and then extension, we call it counter-nutation. I just wanted to go over that really quickly with everybody so that you can see that if you have any problem in any part of the body, you could have a problem elsewhere in the body as well. Okay? Also coming out with the phrenic nerve and the vagus nerve, if you're getting some compression or craniocervical instability and or cranial settling, you can get some impingements on these nerves as well. And they can cause problems in your throat, your neck, your heart, your lungs. Okay, so I just wanted to go over that really quickly before I start my PowerPoint presentation. First, I have nothing to disclose. I have no potential conflict of interest. Discussions in this presentation are for general information purposes only. This lecture is not to be meant to take the place of your physician or your physical therapist. Pictures in this presentation, all my patients that I have pictures of in this presentation have verbally and in writing signed a consent form saying that I can use their pictures in this presentation and future presentations. Therefore, there are no HIPAA violations. Right. Goals of this presentation are for you to understand proper body mechanics, posture, and why they're important in positive patient outcomes. Understanding the combination of manual physical therapy or osteopathy and therapeutic exercise will give you more positive results than just therapeutic exercise alone or manual therapy alone. And at the end, what should you look for in a good physical therapist? How many of you have been told by doctors that your pain is in your head? I know a lot of patients that I see before they see Dr. Hennison. A lot of these patients that I see have been told that they're crazy, that their pain symptoms are in their head and they don't know why they're having them because a lot of their testing results are not accurate. So, well, I'm here to tell you, your pain symptoms are in your head. Correct me if I'm not wrong. Medullary kinking is in your head. An abnormal clavioaxial angle is in your head. An abnormal Grab-Oaks measurement is in your head. Cranial settling is in your head. Basilar invagination is in your head. A Chiari malformation is in your head. Cerebrospinal fluid blockage is in your head. The problem is, with craniocervical instability, Chiari malformation, the signs and symptoms are the same as many other diseases and syndromes, making it difficult to accurately diagnose you. These are some common conditions and comorbidities associated with a Chiari malformation and Ehlers-Danlos syndrome, craniocervical instability, cranial cervical spine instability, Chiari malformation, a syringomyelia, a tethered cord, dysautonomia, hydrocephalus, spina bifida, basilar invagination, and abnormal spinal curvatures such as scoliosis and kyphosis. Going back, part of the problem also, our diagnostic testings are not always reliable. In Rhode Island, where I see a lot of my patients, they come in with their MRIs on the left. The MRI on the left shows the patient had an MRI done in supine. This patient has Ehlers-Danlos syndrome. You can see right here, this line coming up, that is her clavioaxial angle. In this case, with her lying supine, her clavioaxial angle was 141 degrees. Her tonsils were up and there was no herniation. So the doctor said to her, I don't know what's wrong with you. Your symptoms must be in your head. Then they sent her for an upright MRI, which is over here on the same patient. Her clavioaxial angle went from 141 degrees to 133. If I'm not wrong, the surgeons really considered doing a stabilization surgery around 135 degrees. Anything below 150 degrees is considered abnormal. You can see here with this arrow, her cerebellar tonsils herniated down into her foramen magnum, causing blockage of cerebrospinal fluid flow through here. As you can see over here, there's no blockage of the cerebrospinal fluid flow. Same patient, different pictures or different diagnostic testing. That's why it's important when you get your testing done, your testing is done upright. When you lie supine or lying on your back, a lot of my patients that have connective tissue disorders that are hypermobile, they resettle and things get fixed because they're lying on a table. They're getting a three-dimensional MRI or CAT scan and a one-dimensional plane. There's no gravity or no gravitational forces being put on your neck or your back. When you're sitting up, everything changes. Gravity's pulling on your body, your head comes forward, so your symptoms are going to get magnified, and the doctor's going to be able to see it. The problem is in Rhode Island, there are no upright MRIs. The only two places that I know, down here in Maryland, and I believe there's one in New York. They used to have one in Connecticut, but it's been broken for a couple of years. So craniocervical instability, what is it? It's a structural deficit or dysfunction at the occiput in C1. The ligaments there are too lax, so your occiput will slide on your cervical spine. It can happen, you can have congenital factors where the patients are born with connective tissue disorders, and 1 in 15 patients with Ehlers-Danlos syndrome will have craniocervical instability. The hypermobile part. Acquired, the most common is rheumatoid arthritis, followed by trauma, motor vehicle accidents, particularly a whiplash type injury, or diving into pools, shallow pools, and hitting your head on the bottom of the pool. Erosions by tumors on your odontoid, and Paget's disease. Now, how is craniocervical instability diagnosed? The best way is an upright MRI, a rotational 3D CAT scan, digital motion testing, flexion extension, x-rays, invasive cervical traction. This is a procedure where you would be hospitalized for 48 hours. They'd put a traction unit on your head and lift your head up off your spine. You'll be in that position for 48 hours. If your symptoms decrease, then they may think, then they would look at you potentially having craniocervical instability. The problem with that test is not many hospitals have that equipment. So it's very rarely used. The physician in his office can traction your head, and if your symptoms decrease, that could indicate that you have craniocervical instability. And if they push down on your head, your symptoms will significantly increase, especially neurologically. Now this is looking at the back of the skull. What I want you to get out of this picture is when I do my demonstration with my cane, the back of the skull, the back of the skull here, there are a lot of muscles that attach to the back of the skull. That's these red things. There's a bunch of nerves that are in there as well. It's a very small space to have a lot of muscles and have a lot of nerves. And the white is ligaments and cartilage. On the left, that's your occiput, your foramen magnum. Where C1 meets your occiput, there's a joint. It's right there. We call that a facet joint. There's also a facet joint at C1 where it meets C2, and that's a very unique joint. Both of the joints are convex where they have a rounding on both parts, and that allows them to rotate. So in your neck, where C1 is, in your occiput, you're going to get flexion and extension of your neck and your head. And you're going to get about 15 degrees of flexion and extension both ways. You're going to get about 5 degrees of rotation and about 5 degrees of side bending. Your C2, I did it again. Your C2 I'm sorry. Okay, thank you. Your C2 and your C1, there is rotation. The majority of the motion there is rotation. So the occiput in C1, that's when I asked my son to take out the trash, he goes, "Yes, Dad." It's also, you guys will call it the bobblehead doll position with the craniocervical instability. And when I asked my son to clean his room, "No, Dad, that's the C2 joint." Okay, that gives you side, rotation side to side, okay? Now, craniocervical instability causes stretch injuries, and they can result in nerve damage or nerve dysfunction. Dr. Henderson did a great study in 2004 which showed if the spine is stretched or the nerves are stretched past their ability, and in the spine, I believe in his study it said it was about 17% that the spine could flex, and once it went past 17% of its length and it got into the 18.5 to 20, the nerves in the spine developed what he called axial retraction bulbs. And those bulbs developed inside the nerves, which caused the nerves to die. And that could be a problem when you're overstretching the spine with your spine being unstable. As we talked about before, you have a thickened odontoid, or what they call a pannus formation, a retroflexed odontoid. When the ligament in your neck becomes too lax, particularly the transverse ligament, and your dens or your odontoid will tilt back into the spine and hit the spinal cord or into the brainstem. A Chiari malformation, where your cerebellar tonsils herniate down. Cranial settling, where your skull goes down onto your spine. And basilar invagination, where your dens or your odontoid goes up into your foramen magnum and impinges on the brainstem. Craniocervical instability signs and symptoms. You have neck pain, heaviness and pressure headaches, muscle weakness, dizziness, vertigo, difficulty swallowing, speech difficulty, POTS or postural orthostatic tachycardia, nausea, vomiting, clumsiness, and incoordination. In a Chiari malformation, every case is different. The signs and symptoms from each person are different also. Some of the patients I've seen that have had a 0 Chiari where their herniation is less than 5 millimeters, they've had tremendous symptoms. Where I've had patients that had herniations of 5 millimeters and they're considered a Chiari 1, they've had no symptoms. Or it could be vice versa. The ones with minimal or no herniation have no symptoms, and the ones with the larger herniations have worse symptoms. Signs and symptoms of a Chiari malformation. If you look at those quickly, they're very similar to those. What I liked about this slide is, in 2004, 265 patients by Mueller and Oro, they did a study of patients that had a Chiari malformation. 98% of those 265 patients had occipital headaches. And the percentages that you see to the right of each one of the signs and symptoms were the percentages that the 265 patients had. When you're looking at a study, you want to make sure that the population number is 30 or more. That gives it a stronger statistical significance. 265. That's pretty strong significance statistically. When I'm in my physical therapy clinic, I look for 3 things when I have a patient that has been diagnosed with a Chiari malformation. They get significant occipital headaches, headaches in the back of the head, when they cough or sneeze, or they bear down on their bowels to have a bowel movement, or they're holding their breath and they're lifting something. They'll have neck pain, and they'll also have brisk reflexes. Now, muscles and ligaments, how do they function? Well, we have our muscles on the top left are normal. Your muscles should be off tension and relaxing until you actively tell them to move. Your ligaments, on the other hand, should always be on tension and stabilizing the joints or your spine. And my patients with a Chiari and craniocervical instability, as well as my hypermobile EDS patients, the opposite happens. The muscles are always on tension, attempting to co-stabilize the spinal segments or the joints, and the ligaments go off tension and they don't have stability. The reason why you get the muscle spasms are because your ligaments aren't working doing their job, so the muscles will tighten up to hold the joint in place or hold it slightly out of place in what we call a subluxation. This is a facilitated segment. This is what happens. The thing on the right is your muscle. The thing on the left is your spinal cord. Your muscle sends a signal into your spine when it's working. It sends a signal back out. The one going in we call afferent. The one coming out we call efferent. You get an injury or something happens. It sends a signal to the spine. If you do nothing about it, the injury stays there. It gets worse. As you can see, the signal's gone. If you continue to do nothing about it, it gets worse and goes to a full-blown muscle spasm, and it will take your joint that was in place and pull it out of place. So I just wanted you to understand what a facilitated segment was, or what we call somatic reflex. The goal of manual therapy is to restore maximal pain-free movement of the musculoskeletal system and postural balance. What does that mean? Well, our patients that have craniocervical instability and Chiari malformations, their muscles are on tension. When the muscles are on tension, they're going to cause pain, muscle tightness, spasms, trigger points, and weakness. When a muscle stays on a prolonged contraction, it will fail and it will become weak. Ligaments, on the other hand, will be off tension, allowing the joint to slide, which will cause joint pain, instability, subluxations, and/or dislocations. So the goal of manual therapy is to reverse this process. We want to try and get the muscles off tension and hopefully get the ligaments back on tension. Once we have structural balance of the whole system, we start to do therapeutic strengthening, stabilization, toning, cardiovascular, and proprioceptive exercises. Once the patient is stable, from a stabilization standpoint or a strength standpoint or a tone standpoint, we may begin some very specific stretching exercises for tight muscles or muscles that were in spasm. Only once the spine is stable or the joint is stable. You do not want to stretch a muscle if you do not have stable joints or a stable spine. That will just increase the instability. All right. You're going to have a typical house on the left and a EDS house on the right, or a connective tissue disorder house on the right, or a craniocervical instability house, or a Chiari house on the right. Typical house on the left, typical house on the right. When you go into your doctors and you have that diagnostic testing like I showed you before, it shows them nothing. This is what they see. You look good. You don't look like you have an injury. And that's part of the problem. Because on the house on the left, in a typical house, your house is built with excellent 2x4s, 2x6s, and 2x8s. And they're lined up 16 on center. In patients with connective tissue disorders, their houses are not lined up at 16 on center. It's termite infested. You have weakened collagen and weakened ligaments. And you can see them there as well. So your foundation of your body is not very stable, unlike this house here. And that's what it looks like in the end when you fall down and you haven't had any type of good therapy, or you haven't met somebody like Dr. Lee, Dr. Hennison. Now, I want to talk about posture here for a moment. This is normal posture, where your ear is over your shoulder over your hip, your hips over your knees. A lot of my patients that come in, whether they have connective tissue disorder or not, even my patients that don't have connective tissue disorder, look like this. Their head comes forward, which causes their cervical lordosis to straighten. They're going to push back their thoracic spine into more kyphosis, and their pelvis is going to tilt forward. And that's going to give you a posture like this, which is going to increase and load up your low back. Now, the reason I have this diagram over here, a normal head weighs 8 to 10% of your total body weight. So if you weigh 100 pounds, or in this case, this person weighs 120 pounds, their head weighs 10% of that, it's 12 pounds. If their head goes 1 inch forward, they increase the weight on their neck by 20 pounds of pressure per square inch plus the 12, which gives you 32 pounds of pressure per square inch on your neck. Remember that picture I showed you with all the muscles? And that cross section with all the nerves? Those muscles tighten up and become fibrotic. Muscles are supposed to be smooth and mobile and move. When they become fibrotic, they don't move very well and they tighten up. And if your head goes forward another inch, that's 1 inch, that's 2 inches. And for every additional inch, your head pressure increases by 10 pounds of pressure per square inch. So this head that weighed 12 pounds at 2 inches forward is 42 pounds of pressure per square inch on your neck. Plus, for your low back, it's the same weight. So that 120 pounds of pressure per square inch on their low back plus the 42 pounds. So now the person who weighs 120 pounds has 162 pounds of pressure per square inch on their low back. So I want to do a little demonstration so I can show you what I mean. Dr. Hennison, if you come up here for a minute. This is a 10-pound weight, and I'm going to need a couple of people from the audience if they don't have any wrist issues. You're going to stand this way, Dr. Henderson, first.
Okay.
So I'm going to tilt the head this way. All right, hands down here. That's where your low back is.
Yeah.
A little lower. Hold it straight. So he's going to hold that weight for a few minutes. You've seen he's having a little bit of a problem getting it balanced. I need 4 people to come up. Any 4 people, as long as you don't have any wrist issues. I'm going to have you stand over here, hold that red one behind Dr. Henderson. You do the same thing with the red one behind Dr. Henderson. Dr. Lee, you can grab onto one of the nerves. And you can grab onto the other nerve. Come behind him. You're going to be behind him, though. And so people can see. People, and we'll switch so you guys can see also. Now, this is if the head is straight. There's going to be a little bit of tone on the muscles, but they're going to be more relaxed. Now, in that picture, as I showed you before, if the head goes forward 1 inch, let it go forward, Dr. Henderson. You guys hold it. Don't let go of your tension. And please don't let it go, because Dr. Henderson may get snapped. Don't hold it straight. Let it come forward. Let it come forward. That's what's happening to your nerves and your muscles behind your neck. They're not supposed to do that. If you go forward more, they're going to end up failing. And when those nerves get overstretched, if you read the research that Dr. Henderson did in 2004, it doesn't bode well for those nerves. He's bringing the head back so we can hold it. We're going to turn around so the people on the other side of the room can see, so we're going to do a 180. Keep turning to your left. Keep turning to your left. 90 more degrees. Keep going. Keep going. Let the head go forward a little bit further, Dr. Henderson. You see what's happening to the nerves and muscles? That is not supposed to happen. And so you wonder why you have neck pain. You wonder why you have headaches. You wonder why you get pressure inside your head. You wonder why you don't feel so good. Now the doctor lies you down on the table and does a 3-dimensional MRI and a 1-dimensional plane. Everybody got the picture? Now watch. Don't move, anybody. Don't move. Looks like there's nothing wrong. Something wrong. Nothing wrong. Okay. Thank you. Dr. Henderson, don't go anywhere. I got one more thing for you. No, you guys can all sit down. Okay. When I talk to my patients about posture, your head's a bowling ball. It's 10% of your body weight. The more you weigh, the more your head weighs. Picture trying to hold a bowling ball on a stick. Dr. Henderson, put your hand like this for me. I'm doing his left hand because he's a surgeon. I don't want to hurt his right arm. Face straight. I knew he was smart. I'm left-handed too. All right, so this is what your head feels like resting on your neck. Now your head goes forward 1 inch. Hold it there and don't let it go. It doesn't feel good. His hand's tightening up, his knuckles are all white, his hand's turning white, his biceps are contracting, his forearm's contracting. That's what's happening to the muscles from the back of your skull all the way down to your feet, trying to hold you up. Thank you. So that's why posture is really, really important. Unfortunately, it gets missed. And if you have surgery and you had posture like this, and the surgeon does a phenomenal surgery, and you go to physical therapy, and the physical therapist doesn't fix this posture, because the doctor's going to put your neck and your head in the right position on the table. They're going to, when they do the craniocervical fusion, they're going to try and balance everything as much as they can. But if you stay with this posture, no matter how good his surgery was, it's going to fail. Because the stress that's getting put on the metal and the bones in there are going to cause the level below it now to become hypermobile. It's going to move too much. So you really need to understand posture is key once you have surgery or after you have surgery, and your physical therapist needs to make sure that you're in the right posture. Why is posture so important? Do you know how many hours a day people sit? On average in the United States, it's 13 hours a day. 13. You sleep 6 to 8 hours a day. That means you're standing up only 3 to 5 hours a day. So you're in this position all day, it's not going to help. So you need to get up and make sure you're in good posture. That's really important to understand. You turn the light off, please? Thank you. This is one of my patients who has a craniocervical instability, a Chiari, an EDS. This is her sitting posture, or used to be her sitting posture. If you do not have a shoulder issue, I'm going to teach you an exercise to fix your posture. If you don't have a shoulder that subluxes or dislocates, you can do this. If you have a shoulder that subluxes or dislocates, I do not want you doing this, because I don't really have time to fix it tonight. Okay? So the exercise I teach my patients is a posture re-education exercise. I have them sitting. I don't do this standing, because if you have any craniocervical instability or you have any POTS or some insufficiencies in your jugulars or in your vertebral arteries, I don't want you fainting and passing out, or if you have POTS. So basically I have my patients sitting. I have them sitting up. I put them in a bad posture just like they are. I take their hands. I have them lift their hands straight up over their head, turn their knuckles towards each other, bring their elbows back and down, and I have them rest their arms there. You can see it puts you in the perfect posture. Now from the back, it looks like this. Lift your arms up, turn your knuckles towards each other, bring your arms back and down. And it works all the postural muscles behind your shoulder blades to help strengthen your back and get everything in the right position. If you're a surgeon and you're doing surgery for 8, 6, 10 hours, standing up, lifting the arms straight up over your head, turning them about, and back and down. A couple of times I usually have my patients do it, depending on how strong they are, anywhere from a couple of reps up to 10. If you have weak muscles and very difficult joints, I make sure you're only doing one of them until you get stronger, or I may not even have you do it in case you have any issues with your shoulders, as I mentioned earlier, and I put in the slide here. Do not perform with shoulder instability, okay? Because you don't want to sublux or dislocate your shoulder.
How many times a day?
I tell my patients, as soon as you feel yourself slouching, do it. A couple of them, just to reinforce the muscles and get you sitting in the right position. I had to do this 10 times. That's what she looked like after 10 of them. It fixes it. Hair over shoulder, shoulder over hip. Hair over shoulder, 90-degree angle, sitting up perfect. As I said, most people sit 13 hours a day. And if you're like any of my EDS patients or my craniocervical instability patients, they love to go on the computer and bring me the most recent research. They do a lot of research. And the reason why you do research, and I have no problem with it, it's great because it brings me more stuff in. You're so used to going to doctors or therapists that don't know anything about what's going on with you, you're looking for hope. You're looking for people to be able to help you, so you want to bring them the information that they need. And I'm okay with that. I'm not okay with this stuff. Forward head posture, shoulders not at a good angle, end up with carpal tunnel eventually, neck problems, headaches, back pain. Her hips are way out of alignment here. The only thing that's halfway decent is her feet are flat on the floor, except her left foot's turning out. This is the same person, by the way. This girl and her. She's done some other videos for me. So I had her do a chin tuck, and I have her put her fingers just under her nose and just gently tuck her chin down. I want the top of the head to go up towards the ceiling, kind of like a marionette's holding you here and lifting you up. I don't want the chin to go straight back and you're trying to be in a militaristic posture and trying to get a double chin, because that's going to increase the pressure on the back of your neck. It's more of a swooping motion as a gentle tuck to take the pressure off the head. So it's just a little bit of pressure here. And the reason why I want your fingers under your nose and not on your chin, if you have TMJ, like a lot of my patients with craniocervical instability, Chiari malformation, connective tissue disorders, you all have TMJ issues as well. So if you're pushing on the chin or the mandible, you're going to end up with jaw pain. You don't need to have that. You already have enough pain. So after she does that, this is how her posture looks. And what we did was we fixed her feet because she was a little vertically challenged and she couldn't reach the floor. I wanted her hips to be in a good posture, so we put something on the floor for her to rest her feet. And as you can see, it's taking all the pressure off her neck, her shoulders. She's in a good position, so she's not going to end up with carpal tunnel, not going to have any back problems or knee problems or hip problems. Before, after. And I have her, when she's sitting at the desk, every so often, lift her arms up and turn them out. Or I'll have her do this with the chin tuck. This is really important to me as an osteopath. In the United States, I have a doctorate in physical therapy, and in Canada, I have an osteopathic degree. I do not have an osteopathic degree in the United States. In Canada, I do. So in the United States, I'm a physical therapist. In Canada, I'm an osteopath. There are three main philosophies. Unity of the body. That goes back to this. Your body is innervated through your brain, and it takes care of all the organs in your body, all the muscles in your body. So we have to look at our patients as a whole person, not as just a neck, not as just a shoulder, not as just a back. We have to look at the entire patient. The healing power of nature. Your body has an incredible ability to heal itself. We as physical therapists and physicians just need to get you on the right path. Then we need to step back and let your body take care of itself. In Dr. Lee's case, in Dr. Hennon's case, when they do surgery, they do a surgery, they send you to therapy, we get you doing the exercises correctly, and then we teach you a home exercise program. And your job is to do the exercises so that your body will take care of itself. Because you can't be in physical therapy for your whole life. You got to be able to do things on your own and have control over your pain. By doing your exercises, you will have control over your pain. The somatic component of disease. That means you got to get your body moving. If your body doesn't move, it will fail. When your body exercises and moves, it increases circulation, it gets rid of toxins in the body. So it's very important, after you get aligned, you start exercising. Structure and function relationship. Structure governs function. If you have an alignment issue in your spine, you are not going to be able to function optimally. That makes sense? Mm-hmm. Right? The use of manual therapy. The use of manual therapy means we have to touch our patients as physical therapists. And when you touch a patient, you build a very specific bond with the patient. And it lets the patient know that you care about them. So these 5 philosophies, A.T. Stills was the founding father of osteopathy. These principles were developed in 1880, 1890. That's important to remember for later in the lecture. He knew that we had to align the body and then exercise it in 1880. A.T. Stills was also an MD. He was a surgeon in Civil War. He became unhappy as a MD during the Civil War because 3 of his 5 children died of meningitis, and his wife died, and his brother died of cirrhosis of the liver, and he was unable to help any of them with the common medicines of the day. So he thought there was a better way to do things. So he went and used the knowledge that he had as an MD and took it with the philosophies of osteopathy that he came up with and made this great science of these philosophies. Review of the literature shows that if a patient does nothing, they're going to get worse. They're not going to get better. Therapeutic exercise alone, they had very good results. Not 100%, but they had much better results than the patient doing nothing at all. The problem with patients who have connective tissue disorders or hypermobility, if you exercise too much or incorrectly, or your therapist progresses you too fast, you will fail. Because they're not taking into consideration the hypermobility that you have in your joints. I bet there are a few people in here who failed physical therapy too. All right? Manual therapy alone, they had positive outcomes. They were equal to or slightly better than the therapeutic exercise. But that too was a standalone. They were just aligning the patient, but they weren't getting the patient moving. They did a combination of manual therapy and therapeutic exercise, and what that showed in the research, that the patients significantly got better than doing nothing at all, therapeutic exercise alone, and manual therapy alone. Not a little bit, significantly. And this research was done in the 1980s, the 1990s, the early 2000s, and in the 2010, I think was the last article I looked at. So A.T. Stills said back in 1880, 1890, align the patient, exercise them. And we're finding out today in 2000s, they're saying align them and exercise them. Physical therapy deficits that you're going to have with craniocervical instability, Chiari malformation, or any type of connective tissue disorder that involves hypermobility. You have joint laxity and instability, muscle weakness from underused muscles. You're going to have muscle weakness from muscles that go into muscle spasms because the muscles are too tight and they're not allowed to relax, so the muscle will eventually fail. There'll be a lack of proprioceptive input, particularly with my patients that are not getting good coordination in their feet, particularly with their Chiari malformation, and some of my craniocervical instability patients where they have some cranial settling and their nerves in their neck are getting compressed. And they're going to have poor cardiovascular endurance. The best treatment options, as we just talked about, manual therapy, therapeutic core stabilization exercises, therapeutic joint stabilization exercises, proprioception exercises, and cardiovascular endurance exercises. Structural manual therapy, what I do with a lot of my patients, I utilize these techniques. And these are the techniques that you're going to look for in your physical therapist that does manual therapy. They do muscle energy techniques, myofascial release, Jones strain, counter strain, cranial therapy, craniosacral therapy, visceral manipulation or mobilization, and manual lymphatic drainage. Another technique that you'll see out there too that gets done a lot with these patients is called zero balancing. So now I want to show you a manual therapy treatment session that I do with my patients. I'm not going to talk about the slides, I'm just going to go through them, and I'll show you the before and after picture. I'm just doing a myofascial release to her rib cage and her thoracic paraspinals, a myofascial release to her pelvic floor, a sacroiliac joint decompression, a diaphragm release, a thoracic inlet release, a hyoid release, a suboccipital release where it's appropriate. With my craniocervical instability patients, you have to be careful when you're treating in this area of the neck so that you don't bring on nausea or make them vomit. This is the start of craniosacral therapy. This is called a classic claw grip. This is another frontal release, a parietal bone release, sphenoid release, a nasal frontal suture release, and I end with a craniosacral with what they call a CV4, which is, it just relaxes the whole skull and the neck. When I'm evaluating my patients from a craniocervical instability standpoint or a cervical spine standpoint, I have her in the resting position here on the left, and I asked her to bring her chin to her chest. When she brought her chin up to her chest, she deviated, as you can see, her nose went to the right. Your occiput in C1 will flex, means come forward, side bend one way, and rotate in the opposite direction. Your C1 and C2 do that same thing. They'll flex and side bend and rotate in the opposite direction, or they'll extend, side bend and rotate in the opposite direction. The rest of your cervical spine from C3 down, flex, extend, and side bend in the same direction. But this is where it gets unique. When she lifts her head up this way, this is an occiput dysfunction. So she brings her chin up, her head deviates off to the side. So I know I have to work on her occiput and her C1. She does have craniocervical instability. And I'm just doing, now I'm actually physically doing a gentle muscle energy technique to her OA. It's a gentle isometric muscle contraction. And I do this with my patient also as an alternative muscle energy technique, but I'll also have the patient do this technique on her own for self-correction without my hands there to help balance off her occiput and her C1. So all of my patients I'll do manual therapy on, I will teach them how to fix their own alignment issues, and then I'll give them exercises. This is a muscle energy technique for her low back. Remember I said earlier today that if you have a neck problem, you can also have a low back problem. It's all connected. She has a low back problem, particularly at her L5. She has an upslip. Now when I'm doing these techniques, I'm using a very short lever arm so that she can't hurt herself using any of her joints subluxing or dislocating. And I'm making sure that her contraction or her resistance into my hands are very, very gentle. No more than a couple pounds, anywhere from 1 to 5 pounds of pressure. Now when I'm doing my muscle energy techniques with my patients, I'm looking to move one muscle of the 602 muscles that they have in their body to move one of the 206 bones in the body. So it is a very specific and very gentle technique. And this is for an upslip where she has a short leg. This is for her sacroiliac joint. This is what she looked like before I saw her on this treatment. She came in with a head like this, shoulders rounded, head tilted off to the side and rotated, side bent and rotated. And after I did the treatment that you just saw, this is what she looked like after one treatment. Is she going to stay that way? No. Remember, we got to start to exercise the patient. Okay? So I started her off on some very gentle exercises. When I start my patients with craniocervical instability or any neck issues that have hypermobility, I always put them in their neck brace. She's wearing a Miami J. Dr. Henderson likes to use the Vista. There's also a Philadelphia collar that I like to use. It's this ugly orange colored brace that you can actually cut, and it can be heated up and molded to your neck a little bit better, but it is not as rigid as the Miami J or the Vista. This is another patient doing a isometric. What I wanted you to see was, you see the muscles right there? They're contracting, and she's only using very gentle pressure. I'm making sure in this picture with my hands that she's staying at right angles so that she can't sublux or dislocate her joints. Same thing with Amanda here. I'm holding her elbow just to make sure she stays in the right plane and that she's not getting too much force put through her arms. This is Michelle again. I come up with a way to exercise. If you can't use your hands because of hand problems, wrist problems, shoulder problems, if you deviate and turn your eyes, if you don't have any eye pressure issues, if you turn your eyes to the right, you're going to contract your sternocleidomastoid. If you turn your eyes to the left, you're going to contract your sternocleidomastoid. In this case, you can see Michelle turning her eyes to her left, and you can see her right sternocleidomastoid contracting. Your right sternocleidomastoid turns your head to the left. It will side bend your head to the same side, and when you use both of them at the same time, it will flex your head forward. Then I had her do it with her hand, and I had her add a little extra motion with her eyes because she was pushing too hard with her own head, and it gave her neck pain. So instead of her using her head to push, I had to use her eyes. And this was just a nice stretch when she was nice and stable. This is to show you that I do some stretches with my patients if they have tightness, only after they've been stabilized. And as you can see, she's getting a really nice stretch of her scalenes right there. This is Amanda. This is when she first came in to see us. She could barely bridge off the mat. We started to teach her some bridging exercises. This is her after about a couple of weeks of therapy. Look at the difference in the height. She has had to exercise in her Vista cervical collar, and she had to have a pillow under her head and her shoulders to balance her. In this picture, no issues with her neck, no pain in her neck, and she was able to bridge. And she does have craniocervical instability, Chiari malformation, and hypermobile EDS. This is Amanda when she was on her initial visits doing some straight leg raising, just trying to strengthen her legs and her core. She could barely get her leg off the ground, again, wearing the Vista and using a pillow. This one, a few visits later, her leg is significantly higher, no pillow, neck in a good neutral position. This is Christine. She's lying on her stomach. You really can't see what she's doing that well because of the color of the mat and the pants she was wearing. We got her in a neutral position with her neck. I have her doing a gentle chin tuck with her neck against gravity. She's in pelvic neutral, and she's lifting her left leg up off the table. If you can see her foot right here, this is her right foot, this is her left foot going up. So she was strengthening her buttocks, back of her leg, and her low back.
Dr. Healy?
Yes?
If you're already fused, are all of these acceptable exercises if you've been fused?
Yes and no.
Okay.
It's a double-edged question because I haven't evaluated you yet to see what position you'd be able to exercise in.
Okay.
These exercises are not meant for anybody to do in here today because you haven't been evaluated by me or one of my staff members or by a physical therapist that would know what to do with you. You have to be evaluated first. You have to be structurally aligned first before we let you exercise.
Okay.
Okay? And I will not manually do therapy on you without you doing exercises. So if you tell me you're not going to exercise, I won't see you. Because if you just want the manual therapy, you're not going to get better. You're only going to stay aligned until you leave. You got to get stronger. Good question, though. This is Christine. I had her exercising. She has craniocervical instability, POTS, dysautonomia, a bunch of other issues. But we had her strengthening her shoulders and her arms, and now she's able to do it with a 1-pound weight, keeping good posture. Having her do some bicep curls to get her arms stronger. Having her do some third tubing exercises to work on her scapular strength. Her lower traps over here, scapular strength here. And we have our patients do some proprioceptive exercises, particularly if they have Chiari or they have balance or incoordination issues. We want to make sure that they're doing some challenging exercises because you have to live life. And when they're ready for it, we get them into some proprioceptive high-level balancing exercises. She's on a Bosu ball. If you don't know what a Bosu ball is, that is a hard surface there, and this under here is a balloon. And she's standing on it doing a squat. She has Chiari, craniocervical instability, EDS, hypermobile, POTS, dysautonomia, gastroparesis, mast cell activation. And she can still do these exercises after she's been through getting good manual therapy and exercising. This is her balancing again on the platform with a balloon underneath it on one leg, keeping a chin tuck, good posture, and lifting her leg up. This is challenging for patients who don't have any of your issues. Never mind a patient with your issues doing it. This is Amanda. I have her doing a modified sit-up on a Bosu ball. Notice where her chin is. She's able to engage her core, her arms, her scapula, and she's stabilizing with her legs. We also do some muscle endurance or cardiovascular endurance with our patients. Depending on what you're comfortable with, if you have back injuries, we like to have our patients on a recumbent bike to support their back. You can also ride a regular bike as long as you're not having any issues and you can stay in alignment. We want to make sure your knees don't hyperextend. We want to keep the knees slightly flexed. We also teach our patients self-corrections. This is a self-correction for the first rib, because a lot of my patients have first and second rib issues, as well as other ribs. And this is a correction for her sacroiliac joint that we teach our patients. Now, coming to the end, finding the right physical therapist for you. What should you look for in a physical therapist? You want a physical therapist with a good working knowledge of craniocervical instability, a Chiari malformation, and or any connective tissue disorders. If they're not, if they're willing to learn, that's okay too. Just bring them in the literature or they'll do the research on their own. But they have to be willing to learn. The physical therapist has to be willing to work with you and your medical team. If they're not going to be able to help you. They have to be good with manual skills, with a combined working knowledge of good therapeutic exercise, and appropriate progression of your exercises. They also have to understand that your progression in therapy is going to be different than their regular patients, and it is going to be much slower. This is not no pain, no gain therapy. This is not the Marine motto, pain is weakness leaving the body. This is slow and steady therapy, okay? The physical therapist needs to work with you one-on-one with their hands. They need to have a good understanding, as I just mentioned, slow, steady progression. Another thing that's really important, you should not be out in a gym with one physical therapist treating 3 or 4 patients, running a bunch of people through exercises. You should be in a quiet, private treatment room, particularly if you have headaches. You want to stay away from noisy treatment areas because you tend not to do well with that, at least in my patient population. So all of the patients at our clinic, we have 11 private treatment rooms in my East Providence office, and we go in our rooms, treat the patients one-on-one, and then we set them up on their exercise program after we get them aligned. So again, you do not want to be out in a gym with 3 or 4 other patients and the therapist running back and forth between 3 or 4 people. Again, you need to be aligned, then you exercise. This is my son Ryan when he was 3. He's at preschool in the sandbox. This picture, when I saw it, when I was thinking about doing this lecture, and a lot of my patients tell me, I'm trying to fit into the doctor's treatment box. It's not working. They tell me there's nothing wrong with me. It's not your job to fit into your doctor or your physical therapist's treatment box. It's our job to come into your sandbox and treat you. That makes sense? So that's basically what I meant by that. I would like to thank the Doctors Community Hospital and Jennifer Smith from the hospital for helping me and fixing the PowerPoint presentation tonight on numerous occasions. I'd like to thank the Chiari and Syringomyelia Foundation for having me, especially Dorothy, who's here tonight. And I'd also like to thank Caitlin. She did a lot of support online for me to get me the stuff I needed down here, so I really appreciate that. I'd also like to thank Dr. Fraser Hennessy for inviting me and giving me the opportunity to speak with you tonight. I'd also like to thank one of my colleagues, Dr. Patricia Megan, for all of her help and dedicated work with this presentation. Those animated slides that you saw, those were Patricia's, and Patricia works for me at my East Providence and my Cumberland office, and she also does a lot of EDS patients as well. Any questions?
Do water therapy at all?
Do I do water therapy? No, I send my patients for water therapy. Unfortunately, at my office, I don't have an aquatic pool to do aquatic therapy with my patients.
I guess I should have asked you to advocate that.
Do I advocate it? Yes, depending on the patient and where they're going. What I also have to look at is the facility that you go to. If you're going for aquatic therapy, you need to make sure that it's well ventilated, particularly if you have any dysautonomia issues, any POTS. Because if it's not ventilated very well, it gets really hot in there. The other thing that you've got to take into consideration when you're going for aquatic therapy is the temperature of the pool, because a lot of my patients with connective tissue disorders have some type of circulatory issues, particularly Raynaud's phenomenon. And if you're getting into a pool that's too cold, it could be a problem, or if you're getting into a pool that's too hot. The therapeutic range for an aquatic therapy is 98 degrees to about 102. Anything below or above that is not going to be very good for you. The other problem that you're going to find is when you go into one of those aquatic pools, when you get out of the pool, it can be very cold. Now, a lot of therapy places now will rent a pool in a gym. The pool is separate from where the changing room is, so you actually have to leave the pool, get out of the 98 degree or 102 degree pool, walk across an air-conditioned hallway into the locker room that's cold. And sometimes that can be problematic. But do I use aquatic therapy for my connective tissue patients? Most definitely. And I also use it for my patients that don't have connective tissues.
I've been to a lot of therapy and I've never heard of most of that stuff. So it's quite interesting to me, actually. But I've never heard of it. A lot of us have bad balance. I can maintain my balance 1 second on one leg and 2 seconds on the other leg. So it's really hard for me to do it out of the water, do things out of the water.
Correct.
That's what I was wondering. But I've never heard of most of that. Can we get copies of the presentation or?
It's online. It's going to be online. That's
Okay, cool.
videotaping.
Okay.
Any other questions?
The slides. Interesting.
Yes.
From the doctor's perspective, or when we send our patients to physical therapy, are there any things that we should, for the ones that don't have that much experience with EDS, make sure that they're not doing?
Yeah. They want to make sure that the patient, you want to make sure they're not hyperextending the joints. If they have hypermobile, if they have connective tissue disorders, they have craniocervical instability, you want to make sure they're not putting them into hyperextension. Or positions with a lot of heavy weight. You don't want them exercising with heavy weight. You want to make sure that they're starting off their reps with their exercises slow and steady. You don't want them trying to do 3 sets of 10 of 10 different exercises. You want them to start slow and steady. And you want to make sure the facility that you're sending your patient to, the therapist is going to work one-on-one with the patient, and not one physical therapist is going to be working with 4 or 5 patients at the same time.
And what about the direct spine manipulation?
Could you repeat the question?
Yeah.
I mean, could you repeat it?
Yep. What she asked about, from a physician standpoint, what guidelines should you look for in a physical therapist, or what precautions you should look for or give advice to the physical therapist. One, you don't want them to hyperextend the joints, neck, spine, or any of their joints. You want to make sure that they're exercising the patient slow and steady, and they're not overworking the patient. You want to make sure that the patient is going to a clinic where they're going to work one-on-one with them, and not have one therapist work with 4 or 5 patients at the same time. The second question was manipulations of the spine. Patients that have hypermobility, I don't like them getting joint manipulations, particularly of the neck, because it could cause some very serious issues. There's a difference, and the problem that we have with connective tissue disorder and hypermobile joints, there's a reason why the joint becomes hypermobile, whether it's the ligaments. If the joint is hypermobile, the joint above it and below it are going to become hypomobile. So we need to do joint mobilizations on the joints that are hypomobile so that we can get the hypermobile joint to go back in place, and then we strengthen them. I tend not to allow my therapist working with me to do any manipulations of the patients. And in Rhode Island, it's kind of a gray area when we do joint manipulations with our patients. But I definitely don't allow them to do manipulations of the neck. If they have a tethered cord, I don't want them doing any manipulations of the patient either. So we do more muscle energy, as I showed you in this picture here, which is a mobilization where the bone will go back into place by the patient using their own muscle. Okay.
I have 2 questions. One, you mentioned stretching the scalene muscle.
Yep.
What are the symptoms you get when the scalene is contracted? And the other, much more complex question is, what's your experience with dysautonomia in the thoracic spine?
Good question. Scalenes, again, from my lecture, I will not stretch the scalenes until I know the cervical spine is stable. And if the patient is still having tightness in their scalenes on palpation, I'll have them do gentle stretching. I'll have them stabilize the collarbone, tilt their head, and then look up slightly. I want to make sure that they're not going to get any other symptoms along with that. Only getting a gentle stretch of the scalene muscle on the right side or the left side. It would be muscle tightness, lateral neck pain, pain coming down into the collarbone area, pain on the side or the back of the neck. That's when I'll do the stretching of the scalenes if I still see that. Or if I'm having some range of motion issues with them, I'll have them do some gentle stretching after I know all the segments in that area are stable. The second question that you asked about the dysautonomia with the thoracic spine, it gets a little more complicated, as Dr. Hennison said. The attachments of T1 through L1 in the spine is the sympathetic nervous system. And you have the vagus nerve coming out from the brainstem, which sends back some parasympathetic signals to the brain to kind of calm everything down if the sympathetic nervous system is in fight or flight. Our sympathetic nervous system is fight or flight. Our parasympathetic nervous system is rest and digest. So they have to be in balance with each other when you're functioning. When your sympathetic nervous system is all jacked up, your body goes into a very rigid state. Your eyes dilate, your muscles get really tight, your circulation increases. So the patients will have increased breathing. So with that, our job as a physical therapist is to try and calm down the central nervous system or the autonomic nervous system. Once I can get that autonomic nervous system to calm down by doing some craniocervical therapy on them, Dr. Hennison, their sympathetic nervous system will calm down, and then I can get in there and I can actually have the patient do some therapeutic exercises, some stabilization exercises, or some cardiovascular exercises. But first we have to calm down the nervous system if their body is in a sympathetic response where their nervous system is all jacked up. And a lot of times when my patients come into the clinic, they are in fight or flight because they're in pain, they're in muscle spasms, they've had headaches for 2 or 3 days, their joint popped out of alignment. So before I could actually get in there and actually do any treatments with them, I got to get their body to calm down. And the best way to do that is by doing some gentle relaxation craniocervical therapy to get the body to calm down, then go in there and actually do some joint muscle energy techniques with them, which is more of a direct technique, and then get in there and do some exercises with the patients. I'm not sure if that answered your question, but I hope it did. Yes?
When I'm listening to you talk, the people who have gastroparesis, has physical therapy been shown to improve that diagnosis?
Has it shown to improve it?
Yeah.
In the research? No.
No. How
No.
about in your experience in real life?
I have treated patients with gastroparesis, and I've done some myofascial releases with them and what they call visceral mobilization, and their symptoms have gotten better. They haven't had as much pain in their belly, but did it cure it? The answer is no.
Help.
It has helped and made them feel better at times, but not always. And it's self-limiting depending on what their triggers are, particularly if they have food sensitivities and if they're not watching what they're eating. And you can go in there and do that all day long. It's not going to fix it as long as they keep going into their triggers with certain foods that they're eating. So if they change their diet, I'll send them over to a dietitian to make sure that they're eating a good diet. I'll send them back to their primary care doctor to make sure that they're getting the right care that they need. And then I'll do some pelvic floor releases and some diaphragmatic releases, and that tends to kind of help a little bit, particularly with the muscle tightness and the spasms. Because you got to remember, your intestines are smooth muscle. It's contractile muscle, so they can go into spasm and you have to calm them down. And if you can do that, it may help. But is it going to cure it? No. Will it help it? Maybe. Okay? Yes?
Since people affected by EDS can be on such a wide spectrum of what they can be affected by, what is your evaluation consist of for each patient?
Each patient, I do a complete evaluation of their neck, their back, their ribs, their spine, their feet, their knees, their hips, their shoulders, their elbows, and their hands. And I look at everything. I do a complete evaluation of them, and I check each level of their spine. I do what they call, motion testing to find out which dysfunctions that they have in the spine. Besides doing range of motion and menial muscle testing and reflex testing, sensation testing, I go in and do very specific osteopathic mobilization testing with my patients, and it tells me which way their dysfunction is, and then I'll write all those down, and then I'll try and figure out which one is the primary cause, secondary, tertiary, fourth, fifth, and then go in there and try and do some myofascial release, muscle energy techniques, see if that calms it down and aligns it. If it does, then I set them up on some exercises.
Can we start now?
You had a question?
Would therapy help any, even if you choose not to do surgery?
Say that again, please.
Would therapy help any without, if you choose not to do surgery?
For what?
Chiari?
Chiari? Depending on what your symptoms are,
Everything.
if you have everything, the answer is no.
No.
Because if your tonsils are herniated down through your foramen magnum,
It's not, mine is very small, but my symptoms are horrible.
that is a better question for Dr. Hennison and Dr. Lee, both neurosurgeons. I will not tread on their territory. But no, if you have a true Chiari and your symptoms are very vast, is physical therapy going to help that? I don't think so. I'd like to say yes, but I cannot. Okay, that probably becomes a surgical matter as a consultation with the doctors. Okay, but first you'd have to go through, if you didn't want to have the surgery right away, go through a round of therapy and see if you get a little bit better. Okay, and they could teach you some things like posture to maybe take some pressure off your neck and do some exercise to strengthen your neck a little bit and improve some quality of life. But it's not going to allow those tonsils to go back up. No. Okay. Yes.
How long does it take you to, when you get started a patient on therapy? How much time do you need to put them on the right track and to be able to send them home with exercises and all that?
That's a really good question. I have patients that fly into our clinic from all over the United States. We've had some patients flying from Switzerland. We had a patient flying from Switzerland, from Brazil, from Portugal. What we do is I need at least 6 to 8 weeks to really do some good manual therapy and start them on a therapeutic exercise program. And then if they leave at that time and go back home, then I'll work with their physical therapist over the phone if their physical therapist is willing to work with me on some progressions of some exercises with them. Ideally, I would like to have the patient and work with them intermittently if I needed to, 6 months to a year, to really get them really strong if it was a true hypermobile issue and their segments weren't working really well. But the majority of my patients from out of state come in for a week. So I see if I can help them, and I get them aligned, and I show them how to do a couple of exercises, then I send them back. And there are some patients, I'll tell you, when I evaluate them, and I treat them for a day or two, I know I can't help them. And then I tell them to go see Dr. Henderson or Dr. Lee. It's out of my hands at that point. There's sometimes we can't help. But to answer your question, I like to see the patient in my office at least 6 to 8 weeks, and that way I'll know if I'm going to be able to help, and if I'm going to be able to help their therapist back home. But
Is it possible for them to come back? What's the interval time that you want them?
To check up on them, in the beginning I would like it to be once a month or once every other month, and then as they get better and they get more stable, then it would go out further and further and further, as long as I knew they were doing their home exercise program.
And
Okay.
It's kind of lifelong.
If they don't need to come see me, then they don't come. Only when they, at that point when they get really good, if they don't need to see me, then I just tell them don't come, don't waste your money. Because it gets expensive to be able to travel and put yourself up in a hotel and then go live somewhere where you're not used to being just to go get treated. It gets expensive. But we just do the best we can. Yes?
When you were talking about craniosacral therapy, just because I'm more in the Chiari world and hear about it, and some people say yes, some people say no. Obviously, there's different levels of doctor of all categories. Can you explain a little bit about what you mean about the kind of work you do? Like, do you do craniosacral therapy on other parts of the body? I'm only used to hearing about the head. And then they say, you know, don't move the bones of the head. But I've also heard it's 5 cents worth of pressure, a nickel's worth of pressure.
It's a gram. It becomes a gram.
Okay,
The reason why they use the gram, not all craniosacral therapists are created equal.
okay.
Anybody in this room without medical knowledge could go and take a craniosacral course. They can. Now, do they have the medical knowledge and expertise to get a good qualified treatment at the end? Maybe, maybe not. They can still go throw up a shingle on their door and say, I'm a craniosacral therapist after they take one course. You want to make sure if you have issues like you do with a Chiari malformation or craniocervical instability, and the person that you're going to for your cranial therapy is a licensed physical therapist, a licensed occupational therapist, an osteopath, and in some cases a high-level trained massage therapist. If it's a fireman or a policeman doing it on one of their days off, you got to be a little careful.
But you do it on other parts of the body?
Craniosacral therapy means the cranium and the sacrum. So true craniosacral therapy is treating the skull and the sacrum. Okay? Cranial therapy is just treating the head and inside the mouth and doing the sinuses and doing the sutures of the head. Okay? But can it help? It depends on the level of skill of the therapist. If you have a true Chiari, though, it is not going to cure your Chiari. It is not going to. It may help with some of the symptoms and make you feel better for a short period of time, but as long as that tonsils are herniated down and you're having symptoms, you have to make a decision on seeing a surgeon to see if it's a surgical procedure at that point and how it's affecting the quality of your life.
Okay.
Does that make sense?
Yes. And while I have you, can I ask one other question?
Sure.
What is your take on, what is it called, atlas orthangeal adjustments?
Having your neck manipulated?
Well, when they talk about the tapping, you know, I hear about these things. It all worries me because I don't like anybody getting their neck messed with without somebody like you. And as you know, you're obviously a rare breed because you've been flown in from Rhode Island. I mean, I'm curious, like, how do you know? Is that something you believe in or do or?
Do I do a C1, C2 manipulation on a patient with a Chiari malformation or a patient with a craniocervical instability? The answer is absolutely not.
Okay.
Absolutely not, because you could make them a quadriplegic right there on the table.
Right, that's what okay.
I got 4 children to feed. I'm not going to do that.
Right.
I'm sorry, I'm not going to. If that's what they're looking for, I'm going to give them a consult to Dr. Henderson, I'm not going
Let
to
him
mess
tell
around.
them no.
Oh, no, I'm going to tell them, no, I'm not going to do that.
Right.
And I'll tell them, look, if you have your neck manipulated, you're putting your life at risk. And a lot of the patients who have craniocervical instability, Chiari malformation, or connective tissue disorders, they also have some problems with their blood vessels in their neck,
Yeah,
particularly the vertebral artery, the jugular, the carotids. You don't want to get a dissection.
right.
So I think the statistic is something like 1 in a million people who get manipulated will have a stroke on the table. You guys are already in a position where you have not good blood flow,
Right.
potentially not good blood flow leading to some atherosclerosis in the arteries or some clots. There's no way I'm going to do it.
Okay.
I will look at the patient and see if they're an appropriate candidate for a gentle muscle energy technique like I showed you there, or showing them how to do a gentle self-correction themselves if it's appropriate medically. If it's not, I won't touch it. If I think the patient's a surgical candidate, I'm not going to touch them. I'm going to make a phone call and tell them to go see Dr. Hennison or somebody who they live near that may do that type of surgery.
Right.
Okay?
Thank you.
You're welcome. Any other questions? Yes, ma'am.
Is physical therapy warranted for every patient that has a deep, I think it was called decompression surgery?
Is every patient...
Be for the correct.
Well, I'm a physical therapist. I'm going to say yes. But the answer is no. If you have a decompression surgery and you're not having any problems after the surgery, as long as your posture is good and you're doing good body mechanics and you're doing, you're keeping your head up nice and straight, I'd like to see the patient for a couple of visits just to teach them some strengthening exercise to make sure that they get the right stuff for their neck and make sure that they're in good computer positions. Because if you have a decompression surgery, they can fail. I mean, you can get some scar tissue development, you can get your occiput coming down again, the tonsils can herniate back, not the tonsils, but if they got rid of them, but the cerebellum can herniate down through again. So I want to make sure that they're maintaining good posture. So I would say yes, I'd love to see every patient and make sure that, see them for a few visits if they're not having any symptoms, just to make sure that they're exercising correctly and they have good body mechanics and good posture and prevent any triggers in the future. And then discharge them. If they need more intensive therapy after, then I'll spend more time with them. That make sense? Any other questions?
Thank you so much.
Thank you.
Right? Everybody enjoyed it? Yes. So, a couple of things. The walks are coming up if anybody's interested. Please sign up because it enables us to keep great guys like Dr. Healy coming in and doing things. Just so you know, we're doing the lecture here tonight, but we just did one last night in Ann Arbor, Michigan. Tonight we're here. Tuesday we're in Cleveland, Ohio. Thursday we're at New York City, and tonight, the 5th one. So it's 5 in 2 weeks. So we're really educating around the country, a lot of places, all thanks to the work that you guys do. We're doing I want to share this because I just heard this today. Up at Brown, we're going to be doing a half-day education for doctors with CME credits. Letters were sent out to 27,000, I'll repeat that number, 27,000 physicians. So it's not just neurosurgeons or whatever. It's first-line candidates from Vermont through Pennsylvania to come to it. So I hope it's really, really super well attended. But again, that's something that you have asked us to do, is to bring together doctors and educate them, and we're doing that. At the end of this month, we have the think tank together. We have 40 neurosurgeons, neurologists, physicists, groups coming in to Chicago to sit and round table about new research. Dr. Henderson will be here, of course, he's on our executive committee. But there's a lot going on, and that's all thanks to you, because you're creating that, and we're just seeing it through. So on that note, we're going to be back here July 13th with Dr. Joe Tregaskis. We're crossing our fingers, I think that's right. And I hope you'll all be here. Please participate in the United Night Walks or get your friends. Let everybody know. Spread the awareness so we can get more people involved. And thank you so
Hey,
much.
Dorothy.
Yeah.
I just wanted to let you know, and I don't know if other people know this, but you know, a lot of times these days with funerals, you are asking people to donate to a charity of your choice. My father just passed away, and we did ask that people donate to you, and it's a nice thought. If you're going to throw away flowers, and if this makes a difference and makes a change in your family, to consider it.
Well, thank you, and that's great. And you know, the other thing is, like, we had both sides of it. We have a wedding coming up where instead of getting gifts, that people are asking.
That's
Is it like so
wonderful.
you have the happy, you know, all kinds of great things happening. But
That's
it's
good.
spreading. Like we're all over the country now, and it's a little overwhelming. You know, we're hoping we can keep growing, but I think it's going to be great for everybody. And again, it's thanks to you. So thank you all.
I
Yeah.
just want to mention, we do have some flyers for the walks.
Okay, Shirley, yeah.
And I think Pam brought some
Pam?
flyers for her too.
And Pam, so does everybody know Pam and Charlie? I hope so. I think so, right? And then we have Nick and Mackenzie. I'm just going to point everybody out. Nick and Mackenzie are in the room. We're getting ready to lead United the Hill again this year, coming up in September, where we're going to go take postcards and all kinds of stuff up to the hill, and hopefully get the government going to our side. And when we come back in July, I'll hopefully have more news about the registry. I'll save that for next time. So thank you so much.
Thank you.